My name is Irene Demanis, and I am the Chief Executive Officer of Weiss Memorial Hospital. I wanted to welcome everyone here this morning. We're excited to have you all here with us. How many times have you told yourself or somebody else, my bones ache? Too many. Well, you have 206 of them in your body, and every now and then we all feel it. So we wanted to spend a little bit of time today to talk to you about osteoporosis, which is bones disease. We have great speakers and experts for you today. So we're going to start with Dr. Thomas McNally, who is our Director of Spinal Surgeries at Chicago Center for Orthopedics at Weiss Memorial Hospital. Later we'll have Dr. Nichole Butler and a physical therapist, Holly Phillips, to be able to speak with you today. We also have some fun tours planned for you today in between the speakers, so please take the opportunity to go up to the 5th floor and visit our brand new unit so you can see for yourself what Weiss has been up to. But I don't want to take up too much of your time because Dr. McNally has a lot to share with you. So please help me welcome Dr. McNally.
Thank you all for coming, and hopefully it doesn't get wet on your way out. The pictures, don't worry about the words on the screen. They're for a much better auditorium, but the idea is by the time you get to an orthopedic surgeon and you've broken something, the other two talks later on today are what hopefully will prevent you from getting to an orthopedic surgeon with a broken bone. So osteoporosis is thinning of the bones, and what we want to do is try to keep them strong so that they don't break. And the best way to do that is with diet and exercise, and by talking with your primary care doctors or your gynecologist about maybe being on some type of supplementation of vitamin D and calcium. So vertebral body compression fractures is getting more and more common in the United States and in worldwide, with lots of people sustaining fractures. And up until about the late 1990s, we didn't really have good treatments for it. We used braces and we used pain medicine, but any kind of brace to actually immobilize the spine, a cast would have to go up over your head, down past your elbows and down past your knees, which obviously would not be a very comfortable way to live for 6 weeks while you're waiting for the fracture to heal. So the braces that we did use were usually uncomfortable when we rub on people's ribs, rub on people's hips and things like that. So we now have some treatment for it. The part here, hopefully you can at least see the bottom part of the screen. On the right part of the screen is normal bone, and you can see how strong that bone is. That's the structure inside our bones. The outside part is the cortex, or the bark. The inside part is the cancellous bone. But you can see the strength of it compared to osteoporotic bone, where you start getting those big voids. And the reason I started out talking about the other two talks we have today with physical therapy and with gynecology is that preventing your bone from getting weak in the first place is the best thing to do, because once those voids are created, it's very hard to get them back. We have a couple of medicines now that are working in the last 10 years or so, but basically what we want to do is save your bone. Women keep putting bone on as far as strength up until the age of 28, and then it's kind of like a bank. You start withdrawing the bone from there. So a lot of the way I talk about it with patients is like an hourglass, and your bone strength is the sand inside the hourglass. And up until 28, that's when you're putting bone into it, and then after 28, you start withdrawing from it. Up until about 10 years ago, most of the medicines that we had just tried to slow down by making the hole smaller, so you lost less strength, or the strength you lost was slower. But now we have some medicines where you can actually put more sand in that hourglass, which we would all like to be able to do with time, I'm sure, too. So what happens with a fracture is the center of gravity changes. In the middle of the picture on the left of the screen, there's a broken bone with a normal bone above and below it. And when it breaks, it starts changing the center of gravity, and things start moving. And it's a little bit like a lever, where we can't pick up a big rock by ourselves, but if we put a crowbar under it, we can move it. And so if you start changing the lever arm and shifting forward, like the Leaning Tower of Pisa that was leaning like that for 1,000 years, and then all of a sudden it reached a point where it started going too fast, and then they had to do something to try to stop it. So kyphoplasty is a procedure where we try to replace a little bit of the height of the bone that's lost. And you can see on the skeletons on the left side of the screen what people look like when they're standing up straight in their 20s, and then as they start fracturing, they start leaning forward, and then in order to look up at the world, you start bending your knees, and then you bend your knees and you can't walk as far because your thighs get too soft. So a lot of what orthopedics is, the words ortho means straight and pediatrics is child, but basically what orthopedics is about trying to restore function as much as possible. So at the same point, it's also about prevention. So if you can do things to prevent the loss of function, that's better than trying to restore the loss of function. And so for the longest time, it was one of the fractures in the bone that we didn't treat the way we normally would, which is if you break your arm or your leg, we often put a plate and screws or a rod in to try to do it. Fractures, once you have one, you start having an increased risk of having more. So basically the way the bones fracture is the bone inside the cancellous bone acts like a scaffolding. When you're working on a building, the scaffolding outside a building. If you take one or two of those poles out, it's not a big deal, but if you take too many, then the bones start collapsing. And so if someone has an osteoporotic compression fracture, not only the bone that reached the tipping point where it was breaking, but all the other bones are just as weak. And so once you have one fracture, either a hip fracture or a wrist fracture or a spine fracture, the chances of having more go up significantly. There's different kinds of osteoporosis. There's the primary kind, but most of us are most familiar with is just as we age. And then there's also some osteoporosis caused by medicines that people take for a long time. Steroids are often the culprit. And then there's also people with endocrine problems, and then severe disease, and then lesions like tumors and trauma. Osteoporotic fractures, even when people have normal Dexa scans, and that, I guess that goes into prevention too, which is more the theme of my talk rather than what to do after something breaks, is to try to prevent it, is Dexa scans. Women are recommended to have them every 2 years after starting at age 65, and then you supplement your calcium and vitamin D if needed, while you try to stay as active as possible, things like that. But another definition of osteoporosis, even if a Dexa scan is reported as normal, is someone that breaks a bone or a fragility fracture. So sometimes when people's bone gets so thin, they can literally break while they're sleeping in bed without any trauma. So obviously that's what we want to do, is prevent your bone from getting that weak. But if one does break, we now have pretty good treatments for it. Actually, the first kyphoplasty that was done in Chicago was done at this hospital when I was a third-year resident by Dr. Frank Phillips, he's now at Rush. But so Weiss has been at the forefront of this for a long time. And you can see on the right side of the screen, this is a normal bone. On the left side of the screen, you can see the fracture, and you can see how things are changed a little bit, leaning forward. Orthopedic reduction, like I was saying before, make the child straight. Orthopedics means put something back where it belongs. That's what reducing a fracture is, to try to put the bones back where they belong. And so this is a minimally invasive way called the kyphoplasty, where we put a little balloon into the broken bone, we blow up the balloon, then we deflate the balloon, and we fill it with cement. How do we do that? There's safe passages into the bone. So the big red slash that I just put on there, that's where we get into the bone, but that's also where, if it came to it, where we're doing different kinds of surgery, that's where we put a screw. And that's how you get a screw in to bone down this red line, and you miss all the nerves in the spinal cord. From the side, it kind of looks like that. This is just a little video of it. The balloon goes in. We try to restore the height a little bit, so we blow up the balloon. Then we deflate the balloon, and then through that same tube, we put in the bone cement. So the cement that we use is the same kind of cement that dentists might use. It's also what hip and knee surgeons use for hip and knee replacements. And this is just an x-ray from a study that was actually done here at Weiss, where there's a broken bone and you can see it squished. I describe it as kind of like if you took a marshmallow and dipped it in plaster and then you squeezed it. That's what happens to the bone. It's not just broken in the middle, but the whole thing kind of collapses a little bit. And then so this is a wedge shape, so it's shaped like somebody squishing a marshmallow, and then we put the cement in and that opens it up. And this is one of the studies that we did. It was published in 2003, but it was done in the late 90s here at Weiss. So again, the theme of my talk really, and even when, as I was saying, that when the first kyphoplasty was done in Chicago was done at Weiss, and then when I was very early in my career, I would go out and give talks to different doctors and things like that, and I would talk to the people that invented kyphoplasty, and I said I would like to be paired with someone from a pharmaceutical company who would talk about prevention. And so I'm very much into prevention rather than trying to react to our problem. Anybody have any questions?
Could this be applied to the knee?
It actually has been not for arthritis of the knee. Most people have knee pain, but some people have tibia fractures. So that's the shin bone, and it can depress, kind of just like that same thing where I was talking about where the joint line comes down. So they have been using balloons like that and supplementing it either with bone graft or with cement.
Even if it was bone on bone in the knee?
No, so it doesn't work for arthritis. It works for some fractures. And they've tried it, not this exactly the same thing that I'm talking about, kyphoplasty, but they've tried the balloon to work to try to reduce or push the fracture fragments back up where they belong. But for arthritis, if it gets to the bone on bone and injections and physical therapy aren't working, that's where a knee replacement would come in.
Thank you.
You're welcome.
Hi, you mentioned there's some medications to help build bone.
Yes.
Can you talk about those? I guess how they work, their success, and especially side effects or other considerations you're taking?
I can, but I'm not an expert in that. So I'm a orthopedics. So what they do is they talk to us about that we are reactionary and that we try to restore function. But just like my sports colleagues, where we try to get athletes back on the field, the same kind of thing. And so what I talk to my patients about most of the time is that they discuss it with their primary care doctor. Often, the women in their 40s, their only primary care doctor might be the gynecologist, so the gynecologists know all about it. Primary care, if someone has bone that's so thin that it's breaking without any trauma and things like that, I usually recommend that they talk to their primary care doctor about a referral, or I'll refer them myself to an endocrinologist or a rheumatologist. So endocrinologists, they work on all the different glands. Bone is a balance in our bodies of trying to put down new bone and take away old bone to remodel. And then rheumatology is their doctors that take care of bones and joints without operating, but they're very good with their medicines. And so the simplistic form of it is the medicines that have been around for 20 years, those are the ones that kind of slow down how much bone you lose. And in the last 10 years or so, and another one just came out a couple of years ago that actually built the bone back up. So when I used to give this talk, I would say once those voids were created, you couldn't build them back, but now they have bone medicines that do build them back. The scariest one for the bones, that the medicines that work to build bone back, was they were in rats. There was concern that it caused osteosarcoma, but the doses that they were getting are huge, and in humans that hasn't turned out to be the case over the last 10 years. But all the there are probably 20 different medicines, and the doctor would go over with you individually which ones would be better for you and which side effects you might be better able to tolerate. Sorry, yep.
When you insert that cement, does it ever move, and what are the adverse effects? Are there any of that type of
So before kyphoplasty came to the US in the 1990s, Europe had been doing what was called vertebroplasty for a long time, and there's still a lot of people that get vertebroplasties. The cement, when we mix it, it starts out as a powder in a liquid. We mix it together, it goes through a liquid stage to kind of a toothpaste stage, and then it turns to rock hard bone cement. And so vertebroplasty is, we didn't create the void, and you would put the cement in when it was very liquid, and sometimes it would leak out profusely, where it would go either into the blood supply or it would go into the canal, and as it solidifies, it's a exothermic reaction, meaning that it gives off heat, and so people were losing function with their spinal cord and things like that. But by using the balloon first and creating that little bit of a pocket, it's kind of like if you put your finger into wet sand, you can fill that for a little bit and hold the water for a little bit. And so we put the cement in when it's a little thicker, like toothpaste, and it's a little easier to control. But that's the main thing, is that it can leak out a little bit and cause problems.
When I saw you, you ordered a Dexa test for me. Do I have to wait until next year to get my other one?
Dexa scans are usually like every 2 years.
Okay.
And most people that see me in spine surgery, they often have a lot of arthritis either in their back or in their hips. So usually if you have a lot of arthritis, I recommend that in addition to the back and the hips, that you get the Dexa to include the wrist. When it's just screening, you don't necessarily need to use the wrist, but if you have a lot of arthritis, those two areas often make the bone look denser than it actually is. Oh, sorry, there was a lady in the back.
Yeah, you recommend to do the bone test like every 2 years when you're 28?
No. What I was telling you about that is that bone, men and women build up bone up until about age 28. The Dexa scans start at 65.
Okay.
Unless you have risks, in which case your doctors will order them earlier.
That's what I want to know. When you are 65 and you are taking D3 and calcium, how will you think I should go and take my bone? Or should I talk to my PCP?
Talk to your PCP and they'll order it, and I think they're even having a discount on them here.
Thank you.
Yep.
As far as the
Kyphoplasty.
kyphoplasty, is that something that can be put into like ankles or feet when you're having multiple problems with the fracture there?
It's theoretically, but I don't know if anybody's doing it. I've only heard about it in the wrist and in the tibia, the shin bone.
Question over here.
How is polio?
I'm sorry, I missed it.
Polio. The shot, the injection.
Prolia.
How is that help?
Prolia is one of the medicines that that stops the bone loss.
Does it replace it or anything, or just stop it?
It stops you from losing it. It doesn't, as far as I know, it doesn't build it back up. But usually people that are on Prolia are also told by their doctors to increase their vitamin D and their calcium in exercise. So weight-bearing exercise, the reason our bones are shaped the way they are is because bone reacts to forces. So if you put pressure on the bone, it gets stronger. If you don't put it in, like even at bed rest, people lose bone very quickly.
Would you say that it's genetic? I literally saw, you had the picture of the 3 people. I saw my mother progress to each one of those stages. And I mean, it was incredible, right down to every detail that you showed there, exactly right there, where she was bending her knees, bending forward. Would you say it's genetic?
There is a genetic component to osteoporosis, so that's why I was talking about Dexa scans start at 65, unless you have risk factors like a family history of it, or early menopause, or if you've had your ovaries removed surgically or something like that.
Okay.
So then you start the Dexa scans earlier.
Okay.
Aren't there any medications that actually build bones back up?
There are now. In the last 10 years, there is, I think Forteo was first, and then Timlos, and then Avinity. And I think they have brochures back there at the back. And those are all ones that I feel very strongly about, because before they even existed, I was always talking to patients and other doctors, and I'd much rather, I'd like to do this procedure. It works 95% of the time, and there are very few things in medicine that when we tap on somebody's back and the level is where the pain is, and the MRI shows that that's an acute fracture, it works 95% of the time. So as a doctor, it makes me feel great. But unfortunately, I've had some people over the years where I do that, the patient feels great, and 2 weeks later they come back with a new one. And then we do it again, and so we don't like to just keep operating. It's way better to prevent it. So just like our grandmothers and mothers would say, an ounce of prevention is well worth the pound of cure, or better than a pound of cure. I'm also biased because, unlike osteoporosis, if the bone is stronger, my screws that I do for other surgeries have a much higher chance of sticking, rather than like a screw in a drywall. It screws into stronger bone, so it's better. So the stronger people are, the stronger their bone, the better it is. And the more active you are, the better your balance. So the stronger your bone, the less chance you're going to fall and break a bone. I think that's it for me then.
Thank you.
Talk and stay to listen to Dr. Butler. I want to welcome her. She's a seasoned gynecologist with a passion for education and communication. She's a strong advocate for advancing gynecological care of women during their reproductive years and since the early days of her practice. She prides herself in advancing her clinical and surgical skills in apparel with the Division of Obstetrics and Gynecology. She completed her undergrad education at Howard University and received her medical degree at the University of Illinois. She did her residency at Rush University. She is board certified. She has a special interest that includes fibroids, pelvic pain, and sexual dysfunction. She's an aggressive, minimally invasive surgeon with strong diagnostic skills. She has excellent communication, and she deals with a lot of diverse patient population and is focused on helping patients become breast aware and reinforcing the importance of wellness. Let's welcome Dr. Butler.
Hi there, good afternoon. I'm Dr. Butler, like she just said. I'm one of the 2 gynecologists here at Weiss Memorial Hospital. Thank you for coming out today. So I was asked to speak to you about bone health, obviously in women, because as a gynecologist, that's who I deal with only. I don't see male patients. So I'm gonna start with I don't really need that. So we're going to talk about the premenopausal woman first, and then we'll get to really what it looks like will apply to most of you women. Most women that are premenopausal do not have bone issues unless they have a genetic issue or something like that. Most women before menopause have relatively healthy bones. That doesn't mean that bone health isn't a priority. So it is something that I discuss quite often, because once young women leave the pediatrician, they should transition to the primary care doctor, but most times they transition to the gynecologist. So I am the person that sees more young women generally when they move from the pediatrician, because I'm addressing sexual issues, contraception, and things like that. And many times I'm the only person that they see. I deliver their babies, things like that. So many times I'm the only one they see. So I do have to address the whole woman, even though my area is gynecology, which is just the female pelvic organs. I do have to address the whole woman, because many times I'm the only doctor they see in the year. So I do address bone health because I feel strongly, and I think that the research has borne out, that the best way to have strong bones when you go through menopause is to have strong bones coming into menopause, and that is the premenopausal woman. So what do I discuss with the premenopausal woman? So if I have a patient that she's looking for contraception, we do have a specific contraception, Depo-Provera, that the younger women do like because it's every 3 months. They come in, they get a shot, they leave, they come back in 3 months, they get another shot. So we give them a total of 4 shots a year, and that's their contraception, which that's pretty good contraception. That's very appealing to people that don't want to do something every day or every month. They come in quarterly and they are good for contraception. The downside to that particular form of contraception is it causes bone loss. We know that. The manufacturer has printed that in all of their literature. It is a very good form of contraception though. So I use it quite a lot, especially in my younger patients, even teenagers or early 20s that really can't remember to take a pill every day or really don't want to remember to take a pill every day, but they are sexually active and they need to prevent unwanted pregnancy, which is significant. So I have to talk to them about the fact that the manufacturer in the packaging says they shouldn't use it for over 2 years. I do use it for over 2 years because, as you know, 2 years is not enough time for some young women. They are not ready to start families at that time. They still need contraception. It's working for them. But what I do is at 3 years, I get a bone scan to make sure that the bones still look good. I've been doing this a long time. I've not had a young woman whose bones were thinning on Depo-Provera. I still check. And then after that, I still check every 2 to 3 years, depending on how long the patient wants to be on it. I check to make sure that her bones are well. As long as they're well, I am not into unplanned pregnancy, and I certainly don't think that that's any road that any woman willingly wants to go down, so I keep them on contraception. We have another disease process called endometriosis, which is very, I see a lot of it because I'm a gynecologist and I address it specifically. There's a medication that we use to treat it. There are several, which go under the classification of GnRH agonists. And what they do is they put a woman in menopause because that is the treatment for endometriosis. Endometriosis is a pain syndrome, and it can be terribly painful for some women and really interrupt their lives. So we put them on the medication. It helps with the pain. It helps to clear up a lot of the endometriosis, but once again, we can't keep them on it for a prolonged period of time. So there's one that we used to use, I don't use very much anymore, but I still do, called Lupron. Maximum time on that was 6 months because it puts you into menopause and you get bone deterioration. Now we have some other oral medications that we still use, still very good. We have a little longer time that we could use for the patients, but still 2 years is the maximum for that. So those women, once we've had them on there near the max, you get a bone scan to make sure that their bones are intact. But they still have to come off. They cannot stay on. We have to give them a rest, and they can go back on at a later date if we deem that that's necessary. So as far as the premenopausal woman goes, those are kind of the things I discuss with them. The most important things, though, are a healthy lifestyle. So vitamin D and calcium. They don't necessarily need to take calcium over the counter if they have a healthy diet. And that's questionable with some of our young women. We need green leafy vegetables, things like that. But if we determine they have a healthy diet, then they don't necessarily need to take calcium. Vitamin D is pretty important in the Midwest. We don't get enough sunshine, and we know that sunshine is what helps form vitamin D, and vitamin D is what helps the bones absorb calcium. So vitamin D is very important. And what I've seen when my patients go to the primary care is that if they draw the vitamin D, I'm sure many of you all have had it drawn, it's low. It's because we just don't get enough sunshine. So I advise everyone to get their vitamin D drawn and take over-the-counter vitamin D. You're not going to OD on vitamin D supplementation. So there's no problem with that. So that is basically how I talk to my younger women. Smoking, we know, is a problem for bones. Smoking is a problem for everything. So we know that it contributes to poor bone health. I encourage them not to smoke. And as alcohol also contributes to that, to poor bone health. I don't say no alcohol because I don't think that's reasonable for a lot of people, but not excessive, and alcohol in moderation. So those are the things that I talk about with the premenopausal women. Now, when I get to women that are postmenopausal, hopefully I get patients that were adherent to those things, and when they get to me, they have nice, healthy bones. So what do I talk about with that woman who comes to me? She's nice and healthy, and what are my recommendations? The first thing is to assess whether or not she's high risk, because there are high risk patients for osteoporosis. So five different types: white women, Asian women, smokers, if your mother had a hip fracture, early menopause. So if you fall into those categories, then immediately you're high risk to me. And then we have to talk about what we're going to do next. At that point, we're past the take calcium and vitamin D. Yes, you can do that, but we also need to talk about medication such as bisphosphonates, which primary care doctors generally do. As an obstetrician gynecologist, I talk about hormone replacement therapy. I think hormone replacement therapy does a very good job of protecting the bones. What hormone replacement therapy does is the bone has the outer, which you see the white bone, and then there's the inner matrix. And that part of the matrix is what gets depleted during osteoporosis. Estrogen prevents that from happening and then promotes more of that building. What that does is it allows your bones to bend, not break. As you can imagine, if your bones are not resilient when they fall or get hit, they are more likely to break. So we want resilient bones because they bend, and that's very good for you. Estrogen, I feel, and I think the research is there to support it also, does a very good job of that. The problem I have in talking to people about hormone replacement therapy, and that is a whole different topic, so I'm not even going to take that left turn. We can do that at another time. But hormone replacement therapy for your bones only works as long as you take it. So if you have a woman that goes through menopause at 51, which is the average age, or 52, but we're talking about fractures that are occurring in the 70s and 80s, I'm asking a woman to take medication really potentially for the rest of her life. That's not appealing to most people. To me as a gynecologist, I think it's great, but this is my area of expertise. Most women, the thought of taking something for the rest of their life is not really appealing, even though they know that it's a good idea. So I try to let them know that if we take it, so if I put you on at 51 and I take you off at 60, you're great from 51 to 60. Once you come off, your risk, being a person that's at risk for osteoporosis already, is back to where it was. So that's a decision that women have to think about, decide for themselves. I have lots of different conversations about hormones, but I do think that they're a very good option. Bisphosphonates are medications also that do the same thing. They don't reverse bone loss that's already there, but if we identify you as a person that's at risk, we can start the medication, so it's preventative, and if there's osteoporosis already in place, it can put a halt to it. Very nice option, The problem with that is, as with most medications, there's risks that come with it. So people don't tolerate it with their stomachs very well. Really, they don't like that at all. And after about 12 or 13 years, there's increased risks of different types of fractures. So once again, we have a medication that is good, but after being taken for a long amount of time, can be bad. So once again, that's something that we have to discuss, and a patient has to decide for herself exactly what risk she's willing to take based on her personal history, based on her smoking history, things like that. So the patient that has no risks, so she is a low risk postmenopausal patient, once again, we talk about healthy lifestyle. So weight-bearing exercise is good. That's good for everybody. Everybody should, if they can and are able, walk around, use some weights, dance. All of those things are weight-bearing. You don't have to do a ton of dancing. You don't have to be a dancer, but someone that goes out dancing, getting it as a form of exercise is very good. Weights are good. You don't have to lift heavy weights, but you could lift a 5-pound weight. They even have 2-pound weights. So over time, if you're doing weight-bearing exercises, then that's going to be helpful. So calcium and vitamin D, healthy lifestyle, stop smoking, alcohol in moderation if you must have it, weight-bearing exercise. Talk to your primary care doctor about medications that affect your bones. There are lots of medications that make your bones weaker. If you're on steroids, that affects your bones, for instance. So when you see your primary care doctor and you have a running list of the medications that you're on, it's very important to go through those medications with the doctor and see, do any of them have effect on the bone? Because that's very important. That can change your management, that can change your risk factors. So those are things that even the patient that is not classified as high risk, that she needs to do in order to keep her bones healthy. Now the Dexa Scan, which I'm sure you all heard about, we start typically at 65, and I order it every couple of years for my patients. But the high risk patients, I start at 62. The research shows that that's better. We catch things a little bit earlier and we can start medication. These people are high risk, so we want to find things as early as possible to help with their management. So that is the Dexa Scan. That's all I have. It's an easy and hard topic. There's a lot of discussion that has to be had individually with each patient. It's not a broad topic that it's cookie cutter, that everything that what applies to one applies to all. That's not the case with this, but it is something that is very important because we know that hip fractures lead to death in our older patients. My patients are all women. So that's something that if we can prevent, that's certainly something. Even the morbidity, not necessarily just the mortality, but the morbidity of hip fractures is tremendous. And if that's something that we can prevent, it's certainly something that we need to. Thank you. Okay.
Are there any questions?
Yep, I got raising hands.
What do you think of the bioidentical hormones as opposed to the synthetic ones and the factors, the differences?
Well, I have a lot of patients that do bioidentical hormones. So what you have to do is, there's a lot that goes into that because you have to figure out who's making them, exactly what's in them, what makes them bioidentical, how is that going to be followed, who's following that. So as a gynecologist, I'm a scientist, a medical person. I don't necessarily follow medication that comes from outside that hasn't been FDA approved, things like that. So my question for my patients that take bioidenticals, how are we following this? Who's following this? Who's managing this? Has this been FDA approved? What's in this? That being said, I have a ton of patients doing great on bioidenticals.
So can you, does it have less risk than some of the others?
I would say not, because it's bioidentical. So, and that's what I tell my patients. Say, for instance, I'm just going to go with hot flashes, okay? So that's something that goes along with menopause. So hot flashes come from the depletion of estrogen. Your ovaries are no longer producing estrogen. You get hot flashes, right? I treat you for your hot flashes with estrogen. How do I do that? I give you estrogen. The estrogen stimulates the receptors on the cells, which is like, oh, we've got estrogen now, we can stop hot flashes, right? Okay, great. So if I'm a bioidentical and I'm treating that, then I am stimulating that receptor too, right? What's the decrease? Where's the decreased risk? I don't see it. Because because how it's working is the same way this is working. You see what I'm saying? That if it works at all, it works by the same mechanism. So I'm not sure that the risk is less. You see? So if you have a breast cancer that is stimulated by estrogen, my estrogen pill that I prescribe, is it not going to be stimulated by the bioidentical estrogen? If you think about it, it doesn't really make sense.
Also, I want to know about some of the topical things for vaginal dryness or...
Oh, you want to talk about hormone replacement therapy. So, okay, wait, I won't talk to you. Okay, I can get to that. Yes.
If you're at a risk for cancer by taking HRT, what can you take as a substitute?
For bones, the bisphosphonates. So those are your
What's the name brand on that?
Relaxofen. No, not Relaxofen. Boniva, Fosamax.
Thank you.
Yes. Okay. Absolutely. Yes.
Yeah, could you please clarify about the endometriosis that you said? You said you put the client on menopause?
Oh, for endometriosis.
Yeah.
Okay. Yes. That endometriosis. Not to be too technical and bore you to death, but what endometriosis is there are endometrial cells that are in the pelvis. Endometrium is the inside lining of the uterus, and for some reason these cells have found themselves in the pelvis, causing pain. So how we treat that is to put, and they are fueled, this tissue is fueled by estrogen from the ovaries. So we shut the ovaries down to help the endometriosis dry up. Meanwhile, you're in menopause. So
you go back.
once you take once you stop the medication, yes, you go back to functioning normally. Absolutely.
Thank you.
You're welcome. Yes.
So as a gynecologist, do you recommend either bone prevention, bone loss prevention medicine versus bone regrowth medicine? Or do you even do that, or do you send people to endocrinologists?
So that's a very good question. So actually, I don't prescribe the medications unless it's hormone replacement therapy. I refer people back to their primary care doctor for that. But yes, I am a proponent for loss prevention, because I think the stronger your bones are in the beginning, where we start, is, just more beneficial.
Right, but loss prevention versus bone regrowth?
Well, so bone regrowth, that is really hormone replacement therapy. The other things stop the promotion of osteoporosis, but when you want to talk about growth of that inner matrix, that's hormone replacement therapy. It's why I'm a fan of hormone replacement therapy for that. Yes.
If you have a high-risk postmenopausal female and you have her on HRT,
Yes.
Is there any capacity while they're on the HRT to start doing load-bearing exercise and kind of decrease the decrease that would happen after you take them off, or is that not really seen?
You know what, that information. I have not seen that in any of the literature. All the literature says when you stop that HRT, you go right back to your original risk, which is, I mean, it's tough to tell someone you're going to take something for the rest of your life. My grandmother, for instance, loved HRT, so she took it. I mean, I had to fight her to get off of it at 91, but I was like, she was very old school. So she took it she didn't have any hip fractures, but if you think about taking something for the rest of your life, really starting at age 50, 51 years old, that's a tall ask. Yes.
Yes, in terms of over-the-counter calcium supplements.
Yes.
Is there like a maximum amount that's safe? Because I know there's calcium we're going to get from our diet to some degree. In terms of over-the-counter, is there a concern about how much someone?
Well, we generally recommend 1,000 to 1,200 milligrams a day because you can take too much calcium.
Yeah, right.
You absolutely can. So I don't recommend you go over that.
In terms of that, is that diet and supplements altogether, you're saying, 1,200?
Yes, but generally you're not getting a ton of calcium in your diet, so it's hard to really go all gung-ho without over-the-counter supplementation. Yeah. Yes.
And since, vitamins aren't FDA approved or monitored, how does one know what brand is the real deal and
That's
which
right.
one isn't? Because I've been taking calcium for as far as I remember most of my life, but yet I still have bone trouble.
Yes.
I feel like I wasted a lot of money and time, and I don't know which brand to take.
Well, here's the thing about calcium. So, like I said before, calcium adds to the outer layer of the bone, okay? It doesn't do anything for that inner matrix. It just doesn't. So it's like having a strong outside, but you haven't done anything on the inside. And when this inside goes, that's when you start having issues. That being said, calcium is good for you. It's healthy for a lot of different things. So I wouldn't say don't take it, but I wouldn't say take it thinking that that's all you need to take to have healthy bones.
So you gotta exercise, you gotta eat right.
And understanding that we all have bone thinning as we age. That's a part of the aging process. And I think a lot of people get confused, and it's not your fault, it's really our fault from the medical community, where we have kind of conflated things, thinking that bone thinning is something abnormal. Bone thinning happens to all of us as we age, just like our hair grays, just like we get wrinkles. This is a normal part of the aging process. Osteoporosis is not a normal process of aging, and that's something different. And not everyone will get osteoporosis. All of us will get some bone thinning. Yes.
I've been taking alendronate,
Yes.
and I'm 73.
Yes.
Is there anything else I should be taking?
So how are your bones looking? How is your scan?
As far as I know, fine. I had a wrist fracture a number of years ago.
And so have you had another like Dexa scan? Has anybody looked to tell you, how you're doing?
I'm due for a Dexa scan as soon as I make the appointment. It has
So
to
I
be
would say that's how you're going to tell how well you're doing. Yes.
How accurate are those Dexa scans? I have heard all from it's very accurate to every time you go, it could be different equipment, different this, that you really don't get a reasonable readout.
So I would say that they are good for what they do. But the question is, I'm going to get in trouble for this. Are they necessary? So You know, that is the question. You know, what are we gaining, you know, from that? And did the Dexa scan, was it formed because someone saw bone thinning, which, like I just discussed, is a natural part of aging, and you know, so.
But not even is it necessary. My question is, how accurate are they? Like, you know, if it shows osteoporosis 1 year.
They're accurate.
Osteopenia later.
Well, osteopenia is a non-issue,
Yeah.
but you know, they are accurate, especially if you're getting them at the same place and the same people are reading them, things like that. So I trust that. I do trust them. You know, it's just, yeah. Thank you. Yes.
I got 2 questions. One
Okay.
is, osteopenia, a non-issue, and how much calcium can your body absorb at one setting?
I don't know about the absorption. Osteopenia is bone thinning, which is just what we just talked about. Osteopenia. And so somehow it got on the road that if you have osteopenia, you're going to get osteoporosis. And that's, like I just said, not necessarily true. So if you read about, and you should not, this is what I read about, you read about other things. If you read about it, osteopenia really is just the thinning of bones that happens naturally.
And so,
It's not necessarily a highway to osteoporosis.
okay. So if you're getting a lot of weight bearing activity and you're taking vitamin D and calcium, you should be protected enough.
You should be protected as you probably can be. Absolutely. Healthy diet, your calcium, vitamin D, weight-bearing exercise. You know, you have natural risks though. As a white woman, you're already at risk. You know, so my risks are lower than your risk. I'm African American. I got a little bit more fat on me, so I have a little bit more estrogen, things like that. So my risks are different. So those are the things that that's why it's so individualized. And it has to be, and that needs to be something that gets discussed before someone is in menopause. That needs to be a part of the discussion for pre-menopausal women. Think ahead, because the likelihood is that you're gonna live. You know, there was a time when we didn't live that long, so that wasn't really an issue. The likelihood is that you're gonna get at least into your mid-70s. Fracture, that's a real risk for you. But we need to start addressing it earlier, not when you get to 55. Now what are we gonna talk about your brain, your bones at 70? So, I could keep going. Yes.
Yes, allergic to Bisphosphonates.
If you're allergic,
Yeah, to that medication. What are the alternatives?
well, there's a lot of different alternatives. In that bisphosphonate category, you'll have to talk to your primary care about it. They have, people don't like Fosamax a lot, actually. So, but they have different alternatives to that. Yes.
So, taking calcium supplement and D3 should be taken together. Does that work better? Or can you take one in the morning?
Oh, no, you can take them separately. Yes, absolutely.
It doesn't matter.
No, that doesn't matter. No. Anybody else? Oh, yes.
How does Fosamax work differently than calcium pills?
Okay, so what calcium does is it goes into the actual bone, the white part of the bone, okay? That's calcium. Fosamax prevents the declining or the erosion of that inner matrix. It prevents that and helps build more of that inner matrix.
The calcium is for the outside.
It is, and that's really all it does. Am I getting the?
So one last question,
I
because
love it here. Okay. All right, next question. One more. Okay. I gotta answer her. I'm gonna go personally on here. Thank you very much.
okay, thank you, Dr. Butler. I think a host of really good information. Thank you.
First off, I would like to thank you all for coming out today, for joining us, for learning with us. And thank you for sticking around to the very end. I've seen a lot of you throughout the day. We're having so much fun educating with you and learning from many of you as well. So thank you for that. I am truly honored to present one of our physical therapists here at Weiss, Dr. Holly Phillips. She will be closing out our education today with a discussion on the effects of exercise on bone health and fall prevention. Holly has been working here at Weiss for the last 4 years in our outpatient therapy clinic. She specializes in general orthopedic outpatient care, vestibular care. She's an excellent therapist to help you with your own bone health and joint and strength goals here at Weiss. She received her Bachelor of Science in Exercise Science and also her doctorate in physical therapy from St. Louis University, and she's been practicing for 8 years, so she was practicing prior to coming to Weiss. I'm excited to learn from Holly as well, and without further ado, Holly is here to teach you.
All right, thanks everyone. So, I'm going to introduce myself, but I'm Holly. I work over in outpatient. Working with patients that want to decrease their fall risk is one of my favorite things to do. So, if you're looking for someone, I'm your girl. So today we'll be talking about the effects of exercise on bone health and fall prevention. Just a quick overview, we'll be talking about the benefits of exercise at any age, the bone changes that exercise can help with, and then how exercise can decrease your fall risk, which of course is huge when it comes to our bone health. And at the end, I'm happy to answer any questions. So benefits of exercise, we can increase our muscle strength and our endurance with regular exercise. So especially as we age, that's a big factor in helping us to get through our day without being so tired, our daily activities not having such a big effect on our energy levels. Exercise also improves our heart health, it improves our circulation, improves our brain function and our memory, again especially important as we are aging. Immediately affects our mood, both boosting our mood as well as decreasing the feelings of stress, anxiety, depression. That decreased stress is my favorite benefit of exercise for sure. And then increase in energy levels, which ties back to that muscle strength and endurance. So right away after exercise, the research has shown you actually have increased energy, which that's a big question a lot of my patients come to me with, is they say, I'm already so tired, I'm already so fatigued with my daily tasks, I don't know that I can also do an exercise program. And that's a big point that I educate them on, is actually it does give you a boost of energy, even if you don't feel like doing it to start. And then going back to that muscle strength and endurance with regular exercise, then it can help to improve your activity tolerance overall. So then again, you're getting to the end of the day and you're not so worn out from your daily tasks. And then finally, it improves our sleep. So our quality of sleep, your ability to fall asleep at night, all great reasons to start exercising or continue if you already are. This deserves its own slide because this is another point that I educate people about all the time, is that we can build muscle strength at any age. I think my record for the most elderly person that I've worked with and exercised with is 101. Yeah, good for her, yeah, for sure. So yes, she is not building muscle like my 20-year-old guy that I had after her, but she is still building strength. She's decreasing her fall risk by working on appropriate exercises for balance and strength. So you're never too old to strengthen. Our muscles are still able to build strength, which is big. So, this picture illustrates the difference between healthy bone on your left-hand side as you look at the screen, and then osteoporotic bone. So this is looking inside the bone. If you heard Dr. Butler earlier talking about the bone matrix, this is what she was referring to. So on the left, This is healthy, this is normal, good bone density where there's not a lot of holes, there's a lot of white. That resilient bone that bends but doesn't break looks as though it does on the left. In contrast, on the right, there's this, we call it the honeycomb pattern, where there's a lot of that empty space, so all those dark areas are air. So you can imagine if one of these bones were to hit the ground forcibly with a fall, one of them is going to sustain a lot higher pressure than the one with all those air pockets. So with exercise, the research has shown again and again, it increases our bone density, which is exactly what this picture is showing the difference between. So the more dense bone is going to look like the picture on the left. It also, exercise also increases the amount of bone that we have. So if a doctor were to look at a cross section of your lower leg bone, your tibia, they actually can show a measurable increase in circumference of a person that has been a regular exerciser versus someone that is not. So exercise, our body produces more bone. So our bones are thicker and denser, which, as you can imagine, both of these things result that our bones are less likely to break. So very important. So the best type of exercises for your bone health: strength training, which means the effects that the muscles have when they pull on our bones when we are strength training are going to help to strengthen the bones themselves. Strength training can be using weights. They can be using resistance bands like the ones in your little packet if you picked that up from the PT booth back there today. And it can also be cable machines or kind of those rowing or pulley machines. Any of those are great ways to strengthen. And then another important aspect of exercise for our bone health is going to be weight-bearing exercises, which was also something Dr. Butler had talked a little bit about before too. So weight-bearing exercises means just what it sounds like, putting weight through our bones. That also helps to strengthen them, to have that pressure through them. So this can look like jogging, dancing, golf and tennis, kind of that forcibly through our arm bones is a great way to get that weight bearing. As we age, some or a lot of those may not be as feasible or as safe, so then it may look more like walking or hiking. Could look like stairs, simply going from sit to stand, push-ups, things like that. So anything that you're taking weight through the bones, both arms and legs. So how exercise can decrease our risk for falls. Simply put, the more strength we have, the more stability we have, especially when it comes to our leg muscles. And the more stable we are, the less likely we are to fall. So exercise, as we talked about, can increase the strength of the muscles in our bodies. When those muscles are stronger, then we're more stable. So if you think about, if I'm trying to have good balance and be stable, but I have weak muscles, again, especially in my core and lower body, I'm not going to have very good balance because my muscles are weak. So strengthening is a big part of balance and a big part of decreasing risk of falls. So if you come away from anything, that bottom sentence, less stability, you're less likely to fall. More stability, you're less likely to fall. So the best type of exercises for reducing your risk of falls. So first of all, lower body strengthening. So this can be squats, can also be going from sitting to standing from a chair. If you are able to safely do this without pushing with your arms, that's even better because one, it increases how much your leg muscles are having to work to get up from that chair, which helps to strengthen them even more. And two, it adds a little element of balance. If your hands aren't there to support or push, your body has to keep its balance as it's coming up from sitting. Can also be heel raises and toe raises. So that would be something like this, if you guys can see my feet at all, heel raises. And then just the opposite, toe raises, lifting the front of the foot up. So those are targeting the lower leg muscles, important for walking, for balance. And then hip strengthening. So this could be kicking your legs forward, to the side, and to the back as you're standing. If that's not an option, depending on your body, you can also do that laying down on your back, on your side, on your stomach, kind of kicking those legs up to keep those hip muscles strong. And then of course, balance training is an important part of reducing our risk of falls. So as this person's doing, she's standing on one foot to work on her balance. Balance training can also be as simple as standing as I am now without my hands or with my eyes closed. It can also be standing with one foot in front of the other like I'm on a tightrope. It can also be grabbing a couch cushion or a pillow and standing on that so that the surface underneath your foot isn't perfectly level. That can also help a lot with your balance. So important things to consider when we're talking especially about balance exercises. So these are things that you do want to do, especially if you're starting to work on your balance and you haven't before. So standing in front of your kitchen sink or your counter, so something sturdy. Starting with your hands holding on. So in any of those examples I just gave, I always want to do my hands on first. If that feels easy, okay, now I can try without my hands. Another option that a lot of people like to do is stand in a corner of their home. So if you can picture standing in that corner, so that you have, actually that picture on the slide too shows it, but she's got her hands, could be on either side if she starts to lose her balance while she's working on her balance. That can be a great option too. And then finally having somebody with you when performing the balance exercises, especially at first, just to have somebody right behind you to give you a little tap if you need it, can be a really great idea. And then on the other hand, these are things not to do. So make sure that you are not using, like this picture, a flimsy chair. So by flimsy, I mean if you lose your balance and you're holding on to, even this thing, this podium would just come with me. That chairs you guys are sitting on, it would just come with you. So it's great for a little balance, for light touch, sure. But if you were to actually lose your balance and be falling, that chair's not gonna help you at all. So your kitchen sink, your kitchen counter, can be the back of a sofa. Anything that is very sturdy weighs much more than you. Also, no chairs with wheels, especially thinking about going from sitting to standing, no chairs with wheels. Anything with this, no chairs with wheels, of course. And then kind of what we talked about before, don't try something without your hands. Always do with your hands first. If you feel safe and that feels easy, then you can try without. And then finally, if you just don't feel comfortable or safe with an exercise, don't do it. And with any of these, always ask your doctor or your physical therapist if you're working with one, if a certain exercise is safe and appropriate for you. So how physical therapy can help. As physical therapists, we begin by talking with you a good 10, 15, 20 minutes about your history, your medical background, for sure your goals with physical therapy and what you'd like to improve or accomplish. And then we'll assess your movement, we'll assess your strength, your balance, vestibular or any dizziness if that's also a part of your history. We can certainly work with a lot of that as well. And then from there, then we work with you based on your goals and our assessments on your individual strengths and weaknesses to build a plan, a treatment plan in order to target those weaknesses, in order to progress you little by little to those goals so that long term you're stronger, better balance, less likely to fall, and certainly improving and making.
I've been told that going up is fine, but going down is bad. I'm assuming that going down, if you're not focused and your feet aren't in the right position, you could hurt yourself. So can you give a little bit more?
Yeah. So that question was asking about stairs for anyone that didn't hear. So she's hearing kind of contradicting things about whether stairs are healthy for your joints, going up versus coming down, things like that. So stairs are a great form of exercise. They're good for your joints and your bones for weight bearing, like we've been talking about. Your muscles have to pull, so there's definitely an element of strengthening if you're, working at that level as well. As with anything, whether it's running, walking, stairs, depending on your joint health, your joint integrity, some of these things may be more or less, not necessarily safe, but just maybe more or less good for your body, may feel better or not so good for your body. So someone that has severe osteoarthritis, for example, in their hips or their knees, being on that single leg, carrying your body weight up those stairs is gonna be a lot more work on those knee joints than sitting and riding a bike or going for a walk in the park. It's gonna feel probably not as great unless you've got really good muscle strength to go along with that. And then in terms of coming up versus coming down, so similar, almost the same muscle groups are working. The biggest difference is when you're coming down, we want to be lowering our body with our muscle strength, meaning you don't want to be plopping down, hearing those loud steps as you come down, because that's the force of that movement going through your joints. When we're lowering ourselves down, our steps are quiet, even if that means we're holding the handrail to help with our arms, then that's less force through those joints because those muscles are working to absorb that impact. Good? Yes?
Yeah, they have all these exercises for you to do to increase your bone or everything. But I'm just saying, like, if your bone is so brittle, is there specifically an exercise that you should do instead of doing all this? They have Tai Chi, they have all these different. Is there a particular one that you can do comfortably without hurting yourself?
Yeah, so that's going to vary person to person, and thank you for asking that question. I wanted to mention on the earlier slides too was with all of those exercise examples I was giving, some of them, especially if you have been diagnosed with osteoporosis, severe osteoporosis, where we already know your bones don't have the best integrity, it's not going to be a good idea to be jumping up on those boxes like that one picture. It's not going to be a good idea for you to be running down the hall because we already know those bones, don't have good integrity to begin with. So then that's where you would think more of the walking, the sit to stand, those kinds of things. The heel raises like this where it's not so much pounding, but you're still getting that gentle weight bearing through the bones, and then you're getting that gentle strengthening with those muscles pulling with those. But specifically, it's gonna depend individually. So you could start by asking your doctor, what level is my osteoporosis? What is safe or not safe? And then certainly if you have osteoporosis, a physical therapist is going to be a very good person for you to work with because they can give you an individual treatment plan that may not look like these slides, may not look like your neighbor, because it'll just be for you, and you'll feel the safest with that because you'll know your team is working based on what's going on with your body. You're welcome. Yes?
Do you have a recommendation for hip exercises? I've been diagnosed with osteopenia, and I do exercise every day, but I'd like to know some targeted hip exercises because that's where I'm the most vulnerable.
Yes, so she was asking for hip exercises. She's been diagnosed with osteopenia, which is kind of the step before osteoporosis. So the bones are weak. They're not quite weak enough to get into the osteoporosis label or diagnosis. So I'll turn so I can see you. So in standing, you could do out to the side, working the hip muscles here. You can kick back to work the back of the hip muscles. And then you can also march or kick forward to work the front of those hip muscles. So that's going to generally get those big muscle groups in there. And then it's also worth noting that if I do this in standing, my standing leg is doing a lot of work too to hold the rest of my body up. So it's not just the moving one that's getting the work, it's also the weight bearing through this leg for these bones and then these muscles having to stabilize. Depending on what you're comfortable with, you can also be doing these kinds of movements but laying down. So you could lay on your back, kicking your leg up. You could lay on your side, kicking the leg up. You could lay on your stomach if you're comfortable, kicking the leg back. So in general, those are the main muscle groups for the hip.
And would it be to use a resistant band here?
Yes, so then that would kind of be the next level, would be a resistance band around the knees or the ankles, and then holding onto a kitchen counter, doing some stepping. One of two things, you can literally step apart together, or you could just kick against the resistance band, yes.
So the stepping, I can do the stepping like all the way down the hall, that's good for that?
You could, yeah. And again, I would start with hands-on on a counter. If that feels easy, if you're safe, maybe have somebody with you the first time you're gonna try without hands, because that's certainly a much bigger jump in your balance requirements of your body, because now you don't have the hands and also your ankles are tied up, right? So as long as you feel safe with that, yes, that's a great one. You can do side steps, you can also do forward steps, you can do backward steps. Again, I like to tell people to have their hands on something, but yeah.
Do you recommend like 30 reps? Like what do you think? Per side?
Generally you want to go till your hip muscles feel tired, then you want to rest a minute or two, and then repeat it one more time.
Thank you.
Sure, yeah, good questions. Yeah.
Hi, so in that lady's example, if she came to a physical therapist, how often or how long would she have to go to a physical therapist to learn it and then continue, I guess, on her own?
Yes, very good question. So the question is asking if the previous person or anyone came to physical therapy, how long would it take to work with us? How often would they come? And then how long until they could be good with things on their own? So certainly this will vary person to person. Everything is individualized. But in general, we have a 1 hour consult to begin with to kind of test everything, provide some education on where you're at and the plan going forward, work with you on the treatment plan. And then some people will come in and say, I'm busy or I'm going out of town for the next 6 months. Like, I'm here today. I want you to kind of assess me. Give me like 3 things that I can work on my own. Okay. Some people will come with pain and say, you know, I do want to help with balance and fall prevention, but I also want to address this pain. That's certainly going to take more of a, 6 weeks plus in order to work. So, it all varies, but generally 6 weeks is the minimum that it takes to build strength in our muscles. So, yes, you will see little improvements in it getting easier to get up or, less tiring during your day, things like that as you start an exercise program. But to see those big improvements in our muscles' strength takes a minimum of 6 weeks. And that's if you're good about doing things 3-4 times a week in order to build things and make a change in your body's tissues. So generally I would say 1 month, a month and a half is pretty standard in terms of the lower end. And then 2-3 months would be towards the upper end. And then certainly it could be, longer or shorter depending on the person's goals and how they're doing with things and if we hit any hitches along the way and things like that. But generally an outpatient, you're coming in to see us about once or twice a week for something like this. Post-surgical would be possibly 3 times a week. So again, it all depends on the person, but generally, especially if you're not having any pain goals and you're just coming to work on the strength and the balance, it's more about giving your body time to build that strength and to gradually increase your program's intensity. So once a week would be a good frequency for that.
Doctor's order to see a physical therapist?
Yeah, so doctor's order or a referral saying physical therapy for balance or physical therapy for hip osteopenia. Sometimes they'll write a frequency and things like that on there. Sometimes they won't. The biggest factor is going to be your insurance. There's millions of different insurance plans out there, so some of them will say there's a limit per year or there's a limit per this and that. So again, we would help talk you through that on the first day so you understand what your benefits are through your particular insurance plan. And then, yes, that's a good question. That definitely also affects how often you're coming in and how long your program. Yes, for sure.
You emphasize, I assume, that in between your PT appointments, people need to work on their own, which I have friends that do not.
Yeah.
And no matter how much I tell them, you can't just rely on your appointments.
Yes.
So, that's so important.
Yes. Yes, so I'll say what she said again because I say it every day to people. You can come in with PT or for your exercise group once a week, great. But if you're doing, not much on the rest of the days, it's going to be hard to make good progress for sure. It's going to take longer. It's just to your benefit, especially with all of those, benefits of exercise in general. Those things don't kick in by doing things, once a month. That improvement in your heart health and improvement in your strength and endurance come from a regular, a few times a week doing something. So yes, I definitely tell my patients that a lot. And we're all busy. It's not that you have to do things every single day, but just the more you can make it part of your routine, the less it seems like it's something that you have to remember to do because you just get used to it. And then the more likely you are to stick with it, which especially as we get older, if you're just already in a routine of doing this on Monday, Wednesday, Friday, it's just that much easier to keep up with all these things, yeah. It's like I planted you in the audience to ask me that.
Pardon me?
It's like I planted you in the audience to ask me that. Because as a physical therapist, we're always like, are you working on things on your own?
You have to do it every day.
Yeah, thank you. Yes.
I had been in physical therapy and I asked my physical therapist, can I show you, am I doing this right? And then
Great.
I wasn't doing it right, okay, because I was doing it the easy way. Doing it the right way was the hard way, so he showed me how to do it, and I said, oh, I haven't been doing that. And he bust out laughing and said, yeah, I can tell. And then after that, I would go back and I'd say, I want to show you I can do now. What I can do, can I show you? I was like a little kid.
Yeah, certainly there's exercises great. There can be the most efficient and the best way to do an exercise, and then a step down whereas you're still moving, you're still getting things moving, but it could be a little more efficient in terms of targeting the certain muscle groups that are weak for you as an individual. So a physical therapist, that's definitely one huge benefit to working with us, even if it's just once or twice, is just kind of going through your program, and we can make little tweaks that can make a big difference because your body is smart. If there's certain muscles that are weak, if there's certain areas that just haven't been used in a long time, your body knows exactly how to bypass those things. So we ask the hip abductor muscles to go out to the side. Your body knows those muscles are weak. It's just going to turn your toe out, and you'd never know, or you may never know. Or it may lean your body like this. You don't even quite feel it, and then someone points it out to you. Now you know. So that's just one little example, but yes. Yeah.
There's probably a right way and a wrong way to get your day started by getting out of the bed.
In terms of like body mechanics, getting out of bed, is that what you're asking?
Well, instead, some people just get up and move.
No.
Oh. Well, yes. So yes, if you're laying flat, if you're laying in your bed all night, your blood pressure, your little valves in your veins and arteries don't have to work very hard to pump the blood all over because you're laying flat. As soon as you sit up or stand, we got to wake up those blood pressure receptors in order to get the blood now pumping against gravity to get to your brain. And if they don't wake up fast, you're lightheaded and woozy. And worst case, you fall over. So yes, I think what you're asking is kind of getting up more slowly to give those receptors time to wake up themselves. That's one part of it. So I tell people to sit, give yourself 30 seconds. If you feel fine, go ahead and stand. Same thing, give yourself 30 seconds, a minute. Because if you start to feel lightheaded, woozy, your bed's right behind you, you can sit back down or at least grab for some support. If you feel fine, then you can go ahead and walk. Yeah. Was that your question?
Pretty much.
Okay.
I was, after therapy, was told to first sit, get your balance sitting on the edge of the bed, and then
Yes.
slowly start to move up,
Yes.
a little bit at a time.
Yes, and then,
walk.
yes, correct. And then especially as we get older, you know, our bodies, everything is taking a little bit longer. So again, those receptors in our blood vessels are going to be a little slower as we age, which makes it more and more important to take your time as you go through transitions. Same thing if you've been sitting for a while, you know, don't jump up and go. Stand up, make sure you get your bearings, disguise it as a stretch. And then if you feel good, then walk. Yeah. Yes.
Yeah, going to the store and lugging heavy groceries, is that exercise?
For sure. My biceps are tired after I do that, right? Yeah.
Women do it all the time.
Mm-hmm. For sure. It's definitely exercise. Yes.
Yeah, not just balance, but you know, as we get older, our bodies change, and I noticed that I'm like more slumped over, that kind of stuff. Does physical therapy have exercise that can help me
Yes.
get my posture back in shape?
Yeah. Mm-hmm. Because that affects your balance. So as we age, especially depending on, you know, what careers we had or didn't have, what positions we're repetitively in and day out, a lot of us are at computers, looking at our phones. Everybody's like this. If you ride the bus, everybody's like this, right? And then over time,
Getting a little hump here.
yeah, right. So, and gravity's not your friend when it comes to that. So gravity, once you start to go like this, your head weighs a lot and your body's gonna follow your head. So once you start going forward, then you just keep going. Unless you have some good exercises to work on that spinal extension and scapular retraction, just being mindful of being up and back, the more you can do that. That's the simplistic answer. But yes, in therapy, we work on that a lot because being forward is going to bring your whole center of gravity off. So that's going to affect your balance.
So we have enough time for maybe one or two more questions, okay? Thank you.
Thanks. Yes.
I just want to remind my colleagues, there's a saying where I'm taking, fighting, the instructor always tells us, no pain, no gain, no brain. When you are in pain, stop. You're not going to become Arnold Schwarzenegger or whatever. Just stop when you're in pain. That's what I mean.
Yeah. And there's different types of pain, right? There's pain like real pain. There's also muscle pain in terms of soreness and muscles getting tired and burning, which can happen when we're doing strengthening or when we're in the grocery store and we've been carrying those bags for a long time and then we start to get those muscles burning. And that's not a bad pain. That's a good pain. That's helping you to build strength. But yes, certainly if symptoms and pain are being aggravated, you want to check in with what's going on. And if you're not sure if that's a good thing or not, then that's a good time to check in with doctor or a PT about it. One more, anyone else? Or good? Okay, thanks everyone.